All right, I'm thinking we should get started. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Company training space. For those who I haven't met and online, my name is Sean Barinholtz. I'm anesthesia and adult critical care physician at Hopkins. And I have the honor of serving in the medical director's office as CAR 609. On behalf of being here on behalf of the EMS, Captain Willits, Captain Stewart, and for his unyielding support of this training series. Thanks for coming. Thanks for what you guys do every day. Thanks for your dedication to lifelong learning. Captain Stewart has been with Baltimore County Fire Department since January of 2001. He came to the fire department with 3 years at Johns Hopkins Hospital CCU as a critical care clinician and 2 years from St. Joseph Medical Center Community Outreach. Captain Stewart received his education, started at Community College of Baltimore, Essex, with an AAS in emergency medicine, medical services, to obtain his master's degree in public administration from University of Maryland University College. His start in the fire service began as a volunteer in 1989 in Baltimore County, also volunteering in Harford County and Carroll County. He has served in the career service as a firefighter, fire EMS, and EMS lieutenant, and currently holds the rank of EMS captain. Captain Stewart has taught ALS at the state level and helped develop, teach, and administer one of Baltimore County Fire Department's most successful ALS program. His drive and dedication to EMS in Baltimore County Fire Department is quite evident. Thank you so much for your generosity, for being here, for bringing this topic, and as always, for your support of all this EMS training that we've been trying to get underway for the past 18 months. You have accomplished what no other has been able to accomplish. So thank you for that. Thank you.
I think this is on. Everybody can hear me now? Well, that's a little loud. Is that too loud? So I appreciate you coming tonight. I know there's a pretty significant sporting event starting about 8 o'clock, and there's 12 more people than I thought would be here, so that's a good thing. So we'll try to make this a learning experience, and I want to make this a little different than what we've been doing in the past trainings. And when Dr. Barinholtz asked me to do this, we talked about something that would address concerns, problems, if you will, that we've had within the system, not necessarily Baltimore County. And after the last town hall meeting, I got to tell you, I was pretty intrigued with some of the comments and/or talks, discussions out there. And I wanted to some of the things that were relevant to me were some of the providers were talking about how we just don't have involvement. And I think there's a lot of things behind the scenes at a bigger picture, both federally and state, that we just don't understand or see that contributes to what we're experiencing here in Baltimore County. And if you read a lot of the literature across the state and across the country, is that fair to say? So there's two disclaimers I want to share with you all tonight. One, we're not going to talk about any EMS reorg in Baltimore County. And two, I'm not speaking on behalf of the administration. This is me personally that's done a lot of study and a lot of literature and a lot of research. Now we'll apply it to Baltimore County if applicable, but we're not going to get off on a side tangent about the problems that we have specifically. Does that make sense? And I think that's very clear to make sure we have those lines. So with that being said, we're going to talk about a few things. The first thing we're going to do is we're going to go into a case study, but we're going to go into a case study a little differently than we've done in the past. And there's a lot of involvement that I want from you as a collective group here. For those that are online, we'll try to work that in as best as we possibly can. You good? Not jumping into action yet? Okay. I don't want anybody to run out of here all of a sudden. So we're actually going to talk about a case review. We're going to define the establishment of EMS past and present. We'll hold that thought for a second. This is probably for the squad. Now, tonight, one of the things that we're going to talk about, which you probably are like, how does that even relate to EMS, is we're going to talk about the Affordable Care Act. Because I think if we put things into perspective, you're going to see how that kind of put us where we are today. I don't know what you believe of it. We'll talk about that when we get to that slide, but I think it's important to make relevance of it. We're actually going to address some of the challenges faced by EMS system, and this is where I want to hear from you, because we heard a lot of it in the town hall meeting, but I want to hear it here because we're going to try to put it into perspective. We're going to present obstacles that we have to overcome and achieve. I think with everything, you know, there's money involved, there's administrative decisions to be involved, there's higher powers, there's regulations, there's federal regulations, there's state regulations, and we got to make sure that we talk about them and understand why things can't happen yesterday. And then we're going to introduce an understanding and person evaluation for our own demeanor. There's a lot of study out there in the social world, in psychology and sociology, that talks about how our mindset, depending on anything that we could do, changes for the good or the worse, and we can put that to any profession that we're in. So we're going to apply that, I think, in EMS today. And then we're going to outline the importance of EMS as a profession. So let's jump into a case review. All right, a little different than what we normally done. I'm going to stop you right after we present a couple things. You're called to a 28-year-old Caucasian male. Let's just say, for the sake, nobody in here looks like him, so I'm not violating anything. You're called to location for an overdose patient now conscious. Your remarks are, the patient has reportedly overdosed on heroin and was given Narcan leave behind by family. Now conscious, now breathing, but he is arguing and agitated. What are our concerns right off the bat? Anybody got any concerns? Let's talk about this. Let's say that's your patient to a T. Same skin color, same appearance, same demeanor, same presentation. That was him. Is there anything that concerns you about that picture at all? Sir? He might have a heart problem. He's grabbing his chest. Anything else?
Is he altered? Is he agitated?
He's agitated. Yep.
Is he agitated or combative?
Good point.
Safe for us to approach him?
Okay, so we're thinking all the things that we're supposed. Is anybody overly alarmed with that picture right now? Nobody's overly alarmed, right? 28 years old, standing up, just grabbing his chest. That's it. You get a location, police have said the scene is safe. He's agitated, he's argumentative, but for the most part he's cooperative. And we've had that happen before many, many times, right? This is what you see. You walk into the living room, this is his living room. You walk into his bedroom, because that's where he is, and that's his bedroom. Where are the children? Okay, so Gentry sees that there's formula and toys. He wants to know where the children are. The wife got agitated because the girlfriend, whoever, came home, saw him unresponsive, gave him the Narcan, she rolled out with the kids. How about that? All right? He's there by himself. This is what we see. Has anybody formulated an opinion? Man, what's your name in the front? If you don't mind saying it. You can give a false name because we're on camera. Okay, what's your opinion? Have you formulated any opinion? Any concerns? Where do you want to go with this? I'm sorry?
Being sanitary, possibly dangerous.
Okay, not sanitary, possibly dangerous. Not dangerous in the sense of, unless something comes jumping out from that pile of mess, we're not too terribly worried about it, but definitely unsanitary and concerns about what's in it, correct? Anybody form a bias as of yet? Anybody's like, he's 28, he's done drugs, his house is a mess, he's a schmuck. Anybody want to say that, honestly? No?
There's an opinion, but that doesn't sway your actions.
Keep that thought, sir. There's an opinion, but that doesn't sway your actions. We're going to get back to that. Gentleman in back said there's an opinion that we've formed already, but that doesn't sway our actions.
Remember, that's okay.
I'm going to... I didn't use his name. I asked her name, but I told her she could change it. We're going to get back to that because there's a point I want to make with that. So let's take it one step further. As I said, the scene is determined to be safe by police. He is agitated. He is argumentative. However, he is cooperative. His only history is illicit drug use, and he's got no known allergies. Anybody less concerned? Yes, sir.
He's also outside.
Well, in that picture, he was outside, but remember, I said he was in this bedroom when I showed you a picture of the bedroom. Fair enough? So the picture showed him outside. That's just because I got that picture off the internet, truthfully. But he was in that bedroom. He was in that bedroom that had the baby formula and all the other stuff. His vitals are 136/68. His heart rate is 112 and regular. His respirations are 20. His breath sounds are normal. His pulse ox 94. For those of you astute providers that wanted to take a glucose, his glucose is within normal levels. And the only thing that we noted, as this gentleman said, was he was rubbing his chest. That's it. Now, here's what I want you to do. We've already established the fact that based on what we've seen, not a big concern, right? We've also established the fact that we don't know enough to really form a more of an opinion as far as potential treatment and transport. But the gentleman in the back said something very key. We've already formed an opinion, but we shouldn't let it affect anything else. With that being said, we're going to hold on treatment, we're going to hold on transport, we're going to hold on the other stuff, but I have two questions for you. One, does he need to be transported, I should say? And two, can it be BLS or ALS? So by a show of hands in here, who would say that this is an ALS patient and should be transported ALS? 1, 2, 3, all the ALS providers for sure. How about BLS? Okay, less than the ALS, but still enough. And you ladies aren't sure, or you just don't want to give an opinion because you're right there behind the camera, or you waiting for more information? More information, fair enough. Hold that thought. So let's get into everything. So I want to talk about a little bit about the evolution of EMS. And there's a few other people in this room older than I am. One specifically that could probably verbatim give you all of this. But we're just going to briefly go through it because we're going to tie it into a bigger point. Before we go into a little bit of this, I want you to note two things on this slide. 1965 and 1980s, 1990s. Now, what's the time span in years between those two dates? Sir, Tony? What's the time span in years about between 1965 and 1990? 10 years, 15 years, 20 years? About 25 plus years, 20 some years, right? 25 years. So real down and dirty crash course of the history of EMS, and I bet you ladies weren't even born through any of this. Anybody in here want to tell me how EMS started in the United States? Stan?
Me?
Yeah.
Funeral director.
Funeral director. Go ahead and go elaborate on that, sir.
Okay, that's who had discretion. So they would come out and figure out, well, you dead or alive, how's business, and they decide on whether you were going to the funeral home or going to the hospital or the doc's office.
That's probably it in a nutshell. But before all that, somebody got the bright idea that we needed to do something within the United States for traffic accidents and injuries outside of the home and the hospital. Back in the Napoleonic Wars, they had surgeons on the battlefield. In the Korean War, they had the use of the little helicopters, and people would come in and pick up their soldiers and take them to MASH. And then somebody got the idea, well, let's bring that home.
Dr. Cowley.
Yeah, Dr. Kelly. That's a little bit around the 1960s, 1970s, but they got the idea to formulate EMS in the country. The Vietnam War solidified that using helicopters at home. And then right around 1965, somebody said, hey, this is a great idea, let's do it. Out in the Midwest and the West, where they're a lot more progressive and they needed to do it a lot sooner, so they've already started forming fire department-based systems. For those of us in the room that remember Emergency 51, that's where I got my want and start to ride the fire engine, or the medic, I should say. Well, it wasn't either then, it was the rescue car. Somebody said, well, let's get together this idea of how if you want to start a formalized system, this is the things you needed to do. In 1966, the National Highway Safety Act took effect and said, okay, this is what you're going to do. Right around the same time, somebody that owned a funeral home said, well, I got this great idea. They're going to come to me if they die anyway, and that time they usually did because we had bigger, heavier cars and didn't have airbags and protection. I'll just take this hearse out, make it an ambulance, and if I pick you up and you're alive, I'll take you to the hospital. If I pick you up and you're not alive, I'll take you to my funeral parlor. So all these ideas started running rampant, and all these different people got these great ideas, and we started to formalize EMS. Once we started to formalize EMS, we needed to put together an educational process. And then in the 1970s, that's where the National Registry of Emergency Medical Technicians came about. We're going to formalize your education. We're going to train you to be EMTs. 1973, there was 15 required components to putting together an EMS system. If you want to do this, you've got to meet these 15 requirements. We're not going to get into all of them for the sake of time. It's fair to say, even in Baltimore County, with all our problems, we meet all 15 of them, I assure you. We don't. In case we do. Okay, fair enough, Stan. In 1975, the American Medical Association recognized that emergency medicine was its own form of medicine. So that's where things really got solidified for us, and they really decided that, yes, we could be medical professionals, and we could actually provide benefit to the citizens in the country. In 1977, for those of us that are ALS project, yes, sir.
Let's back up to 75 and then recognize emergency medicine as its own specialty. That was basically hospital-wide as far as that was concerned.
Very good, true. Fair enough. So hospital-based systems where they said, hey, we'll put you out there, we'll still kind of manage you and take care of you better. Good point. In 1977, that's where they realized we could step off of the EMT realm and make you a little bit more trained to save a lot more people. And that's where the first paramedic program was developed by the DOT. CRT. For Maryland, it was CRT. Back in the day, it was still EMT, I believe. I think it was just paramedic back then. I'd have to check that out and I had to bring that up.
CRT was around before paramedic.
Was it CRT even back in the day?
Yes.
Okay, fair enough. CRT.
Wasn't recognized. CRT developed out of the fact of shock trauma and Dr. Cali.
Well, I could go into a whole nother lecture about that man. He's God in our right?
Oh, I agree.
And then in the 1980s and the 1990s, that's when they really solidified things and said, this is it. We've got it down to a pretty good science, and I think this is what it's going to be. Now, let me go back a slide. Yes, sir.
You got 15 components up there, and I noticed they narrowed it down to 10.
I think they combined a few of them, like communications and this, and I don't know, Stan. You research that and get back to me. I'll let you. They could have eliminated them. They could have combined them. I'm a little weak on my history to that level, but I'll give you that.
I just noticed concepts.
Not sure if they combined them or got rid of them, but there's 10 now. Made it easier. Now, I showed the other slide. Does anybody know who regulates us at the federal level? Tony, did you pick up on that? What's our regulatory body at the federal level? Department of Transportation, or NISTA, is the National Highway Traffic Safety Act, or the Safety Administration. Now, you ready? I'm going to walk in front of you. I'm going to put a date up on the board, because this is where it gets a little interesting. (2010). Now, for the sake of argument, I don't mean to bore you, but I'm going to read this to you word for word. So in 2010, the National Highway Safety Administration said, hey, we got a good thing going here. Let's keep some momentum and give it direction and put an agenda together. So all these jurisdictions and all these intelligent bodies got together and said, hey, let's formalize this and make sure 10 years out we have a plan and a process to keep this going and make it better. And in 2010, emergency medical services of the future will be community-based health management that is fully integrated with the overall healthcare system. That's key to understand. It will have the ability to identify and modify illnesses and injuries, provide acute illness and injury care and follow-up, and contribute to treatment of the chronic conditions and community health monitoring. This new entity will be developed from redistribution of existing healthcare resources and will be integrated with other healthcare providers and public health and public safety agencies. It will improve community health and result in a more appropriate use of acute health care resources. EMS will remain the public's emergency safety. So a lot was said in that actual paragraph back in 2010 that set us to motion as to where we're going now. Does that make sense? There's a lot of profoundness in that. It set up the social service programs and health programs within jurisdictions and states, and it gave guidance to how we could incorporate ourselves and work together as a group. Now, from a state level, we all know here that we're regulated by MIMS, correct? I don't think there's any question in that. MIMS is our state regulatory body. Recently, MIMS has said, hey, look, you don't have to, but if you want to, here's our way of allowing you to meet the requirements from 2010 and work into system. But it was also doing two things. It was trying to address problems that we knew we were going to have. When I say we, I mean the medical directors and the powers to be at the state level. Emergency Triage Treatment and Transport, or ET3, is a voluntary 5-year payment model that will provide greater flexibility to ambulance care teams to address emergency health care needs of Medicare beneficiaries following a 911 call. So, we've already had the ability to charge patients. This is saying, well, we know you're busy, and we know the ERs are overwhelmed for a number of different reasons, so we're going to give you some options to fix that. Under the ET3 model, the Centers for Medicare and Medicaid Services will pay participating ambulance suppliers and providers transport an individual to a hospital or emergency department or designations covered under the regulations, transport to an alternate designation as a primary care, doctor's office, or an urgent care clinic while providing treatment in place with a qualified healthcare practitioner, either on the scene or connected using telehealth or teletechnology. So that says a lot in a nutshell, right?
Can I say something?
You can, sir.
Okay. I remember back in the 70s, all right, when healthcare and the hospitals started advertising that they could handle everything from a stubbed toe to a cardiac arrest.
Mm-hmm.
And they started taking and shutting down docs and doctors' offices and small whatevers. And along with that, as far as Medicaid and Medicare was concerned, is they were pushing that to the big business of hospitals.
So look, it's fair to say everything's about the bottom line dollar, and the hospitals needed to make money too. So hospitals said, hey, how can I generate revenue? The doctor's officer is taking this revenue, and if they're not referring patients or admitting patients into my hospital, I'm not getting that money. We're going to talk a little bit about EMTALA and how that fits into the bigger picture.
But that kind of changed the mindset of, hey, you know, let's go to doctors or go to this clinic, as opposed to taking and calling 911.
Yes.
Because that was the big time when they were pulling in 911.
Come to us, don't call them, come to us.
Right.
Fair to say also. Now, along came the Affordable Care Act. We're not going to get into a public debate about what you think of it, but the intent was very good. We live in a very well-off country with a lot of money, and we had a lot of people uninsured. So the powers that be in Congress said, let's get together and put together the Affordable Care Act. And the intent in 2010 for the Affordable Care Act was to guarantee everybody had health coverage. Now that's key to understanding. Everyone had health coverage. We know through the years there's huge problems with that, but the intent was if you want to go to the doctor and you need a doctor, you're going to a doctor. It was also created to make change in the clinical practice setting to make better providers and give them more resources to do their job more efficiently, i.e. the electronic reporting systems that we have nowadays. We give our doctors access to the patient's reports. They can actually make better decisions, take care of the patients better, so forth and such, and that's what we got. And it changed the payment system to say, hey, this is acceptable, this is not, because there was always that question of, are you doing this for a reason, or are you doing it to make a buck? So it changed the guidelines. Now, here's what it did automatically, good, better, and different. Within a very short period, 20 million people who didn't have access to health care had access to health care. What problems does that create right off the bat? Stan, I'm going to pick on somebody else because you're my top student tonight. How about you, ma'am? What do you think that did to our health care system?
Tons of people already calling in.
Tons of people just like that. Now, for the sake of argument, let's do some math. We got 50 states, 20 million people. Do you think all 20 million people are in Maryland? I would agree that most of them are in Maryland, but not 20 million. If we did an average, that's 400,000 patients that just got introduced into the healthcare system that may or may not have been before. So that's an overwhelming number. And when you look at the country and you look at pockets of people, it's fair to say that concentration were in larger rural, suburban cities, rural areas. So those hospitals got inundated immediately. Because here's the thing, you got insurance, you can go see a doctor, but the doctors were overwhelmed. So people were like, well, I can go see a doctor, but my appointment's not for 5-6 months out. So instead of waiting for that doctor, they started flooding the ER because, as Stan said, if I can't go to the doctor, well, I'll go to this ER because the ERs want our business and they want to be able to take care of us. We got inundated at the ER.
Well, they were obligated.
Here's where we tie in. If they're going to the ER now for treatment and care, what's the backup system? EMS. So whether we wanted to or not, whether it was intentional or not, we got lumped into that whole surge of patients. So I think that's contributing to our patient load now. But hold that thought, you might disagree.
One other problem was,
Yes, sir.
you had hospitals that closed down in Baltimore City.
Yes.
So you had less facilities for the people to go to.
So as this gentleman said, another thing that happened across the country where hospitals were now closing down because they couldn't meet the regulations and restrictions and changes to the financial flow that were coming in, and you saw a lot of systems merging, you saw other systems closing down, so now you have a system that's already overwhelmed almost immediately, get inundated, and now we got less hospitals. So that created a big problem for us. The cause and the effect. As we said, we had an influx of patients. We had patients that didn't have primary care before, now have primary care, and when they went to go get that primary care visit, they couldn't get it in a timely fashion, so they just went to the emergency room. That started the flood of, well, what can we do to compensate for that? All of a sudden, you saw the doc in the boxes popping up. Now we've got an urgent care on almost every corner. That was to basically handle that new load of patients. And then that also created the educational component of how do we make this work and how do we fit it into the big picture. Now, we'll talk about that map in a later slide, but this is the United States, and this is the opioid epidemic, state-by-state representation. But I want to have a little bit of group discussion. This is where we can tie in some of our own system if we want. But I want to know from the group what you think 3 to 4 of our biggest challenges or problems or concerns are that we have in EMS. Now, if you want to relate it to Baltimore County because that's what you know, then we'll do that. But in EMS in general, what's our one biggest problem you think in EMS? Anybody? Going to write it down on the board over here. How about you, Joe? What do you think our biggest problem in EMS is, sir? You've been around the longest, I think it's fair to say. It's
is inundated with a bunch of stuff, policies, procedures that affect our ability to take care of a patient rapidly, quickly, and efficiently. A good example of this is the color system, the alert system. If we are on XYZ and the hospitals are around us also in that same situation, happens frequently in this particular district, we have to carry a patient 30 minutes away or longer to have the patient taken care of. That pulls our medic unit out of service 2 hours
for
at
an extended
least.
period of time. So we're inundated. We got a system of alerts that's broken. Is it fair to say?
Very much so.
Now you said inundated as far as policy and procedures. I would go one step further and say inundated with policy, procedures, regulations, but overall patients. Correct?
Correct. It all takes time.
One more. I'll get Tony first because he's. How about you, Tony? Call volume. Gentleman said call volume, but I don't disagree with that. I think it's fair to say that we're down lower than we were last year, but across the board, we go up every year exponentially, about average 1,500-ish calls, give or take. And I'm not quoting exact numbers, so don't hold me to that. Jeff, you had something? I'll go back to Stan.
We don't do EMS prevention or EMS education. We pay on the public for fire prevention, but we do nothing to educate on EMS.
Now, I think it's fair to say before I call on Stan, we've already talked about the inundation, right? We've got 20 million patients that they just got introduced into a system 8 years ago that weren't in the system. So that's one problem with the inundation and the patient load. And then the EMS prevention and education. Well, in 2010, VISTA said, hey, look, this is going to happen. It's coming at you. Be prepared for it. And this is some ways to consider that. We'll talk about community health and mobile integrated health in a little bit of a minute, but if you look at the two, Affordable Care Act, NHTSA, Agenda, Affordable Care, somebody was talking at the federal level and saying, hey, this might happen. You might want to prepare yourself. That's just my thoughts. That's some of the literature. I'm certainly willing to take anybody's opinion or knowledge of that. How about, Stan? How about you, buddy?
All right, couple things, okay. One, I go back to, if you got a stump toe, call EMS, education as far as the community is concerned. All right. Another thing is, and I've had experience with socialized healthcare in different countries. All right, the fact that our hospitals are independent instead of working as a group, and they want to manage their own ways. And I know from working the East Side, and I look at East Side Hospital, all right, and then I see how they deal with their volume. And then I look at the Towson hospitals, which don't even come close to handling the volume that the East Side Hospital handles.
So,
because each one's individual in how they're running their show.
I'll buy that, but you lost me on the socialism part of it. What do you mean by that?
No, I've dealt with socialized medicine in other countries.
Okay, and is that a good thing or a bad thing?
Well, it's a thing. Whether it's good or bad, it's got its pluses and minuses. And I'll go with the Canadian system because I was up there on a motorcycle run with a bunch of us, and we had to throw one of our guys into the system because he had kidney failure. And how they operate is, and it's kind of like here with our urgent care centers.
I'm listening.
Where they take in, EMS only transports the ERs. And then the ERs evaluate, and if it's under 48 hours, they cut it loose. If it's over 48 hours, then they transport the hospital.
So you bring up a good point. So we're talking about other means of transport or other means of facility. We'll talk in a couple slides about problems with that, because there are significant problems with that mentality. Everybody in this room, I think, is fair to say that knows that when somebody's got a splinter in their finger and their finger's infected, let's say they've had it in there for a while, and they want to go to the emergency room, I think it's fair to say everybody in here would agree that an emergency room is a stretch.
Wait a minute. Baltimore County,
Yes?
you would transport everybody unless they pay.
Well, we're not going down that road just yet.
Okay.
You're saying in Baltimore County, everybody goes to the ER. I'm not saying that's right or wrong. I'm just saying from a medical patient standpoint, it warrants being seen, it warrants treatment, it warrants a doctor and or a PA or a nurse practitioner or somebody evaluating it. But to the level of an emergency room, that's a different story. I'm not going to get into laws and regulations and finances of Medicare and Medicaid because that's well out of my wheelhouse. But a lot of the hospitals nowadays aren't getting paid for things like that or getting paid for patients being discharged because, again, they're trying to manage that money flow and get those people that are uninsured still insured.
Also with that, the Affordable Care Act, which was supposed to cover everybody, but unless you jumped into that system, you didn't have it. And a lot of your people that insurance, and they're taking and using the ER as
Yes.
their entry to the
Yes.
system.
There's still a lot of patients out, a lot of people out there do not have insurance.
Right.
There's still money available out there in the Affordable Care Act. There's still money to be had.
Yeah.
But the systems are trying to work to get those people and those providers in. All right, so I don't think I'm breaking any rules showing this slide. I think you can get, the site that I got this from wasn't a departmental site. So I think I'm okay showing it. But this is Baltimore County's heat signature. Now, what does that mean? That means this whole entire area, and these little dots up here, is a primary progression or a primary area of where our biggest call volume is. So we can look at this map and say, this is where our resources need to be focused. And why do we need to focus on them? Now, this is a complex, this isn't just EMS. This is county resources, this is social services, this is Department of Aging. This is all the things that are set up to address. And all these departments, the departments in Baltimore County, and Baltimore City, and every other jurisdiction, and in every other state, look at to say, where do we need to focus our needs and why? When the Affordable Care Act got put into play, we had a couple different primary patient groups. I think it's fair to say everyone in this room got into this business to help people. That's clear. I think our department, hands down, is one of the best, if not better than most. And we all truly are here to help people. But I think it's fair to say we all got into the business to run the calls that are really the calls. What I see on Emergency 51 or what these younger ladies see on Chicago Fire and all this other good stuff, that's what we're here for. It's somebody that's not really sick, that don't have a lot of problems, that gets sick really quick. Or somebody that's sick, that gets sick and we can help them. But now we got this bigger problem. Now we have an influx of medically unmanaged, now insured patients. Because remember, they've never been to a doctor before, now all of a sudden they're coming to a doctor. Now they got money to pay for it, now they're introduced into the system. So now they're unmanaged, so they're sicker. We still got a population of uninsured that still have no money and no means to pay for medical care, so they're going to go to the hospital. And then we've got the whole complexity of mental health and substance abuse. That is huge and rampant at a national level. Yes, sir.
Going back to the medically unmanaged and insured, also it took and changed some ideas of, rather than people being reactive, getting real sick before they seek treatment, to getting proactive, and the fact of getting checkups, getting flu shots.
Well, we'll talk about that. We're gonna. That's a segue in a couple slides.
Also with the mental health, and well, I got a whole other thing on the substance abuse, but mental health, we have more or less dissolved a lot of the mental health centers that we did have.
Fair point. Let's talk about hospital wait times. We didn't talk about that over there, but I think it's all fair to say we all agree that hospital wait times, especially in Maryland, are horrific. We know that at a national level, they know that at a state level. It's well documented depending on where you look. Here's a national slide of wait times in the country. If you look over here, our average time at the hospital is between 16 and 43 minutes. And I can honestly say in Baltimore County, from what I've seen, we probably average that on most days, 16 minutes. Now I'm going to call to the gentleman over there. Can I call on you, sir? What's your name, sir? Chad? I knew you were Chad. I just wanted to. Why do you think the hospitals are as busy as they are? Why do you think we have those hospital wait times?
I think it's partially bed flow management in hospitals.
Okay.
It's partially just the number of hospitals per population.
So Chad brings up 2 points. He said bed flow management and the number of hospitals. Does anyone in here understand? Jeff, I'm calling you, buddy. Do you understand how bed flow management works in the hospital?
Yes.
You do? Okay. How about you, ma'am? What's your name? Zippy. Do you understand how hospital flow works in the hospital? No. Okay. Tell me what you know. What do you think you know?
They come to the hospital, they get registered throughout to the system, so they know that the patient is there.
Okay.
And then they triage them to find out.
Hospital gets registered. They get triaged.
And then they kind of see what
And they're seen in the ER, right?
they need to do.
Yep.
Find out where they should go.
What happens when the magical floor is above? So this is what we don't, Stan, I'm not, you get a 10-minute reprieve. 10-minute reprieve. Going back to what you had. So this is really important to understand. This is a huge concept to understand because not a lot of people understand this. We think we go to the hospital and they have a lot of patients and they're not cleared them fast enough. And that's partly true. We know that they've already got inundated. We know that the rural areas got inundated more with all these patients. But here's the thing. Every hospital has multiple floors and multiple wings. And every wing specializes in some kind of care. And every wing has a boss. It has a doctor that's a boss. It has a nurse that's a boss. And those bosses communicate with one boss who communicates with the ER. So here's what happens when this is the red and yellow component for those of you that do not know this. If a hospital goes on red, what does that say, Zippy? They don't have any cardiac monitors. More importantly, they don't have any intensive care beds available, but they keep one available for a crisis. So they have to have one available for an operating room patient that goes bad or an ER patient that comes in cardiac arrest. So realistically, they have one patient, one critical care bed in the whole entire hospital. And then Yella says, hey, look, we're just inundated right now. We may have a lot of hospital beds upstairs, but all these people haven't just talked yet, and we don't really know what's down here to send up there, to send over there, to send over there. Does that make sense? So that process takes a while, and it doesn't happen like that because the charge nurse on the floor has to say, look, so-and-so can go down to the step-down unit, and I can get them down here, but I got to discharge them to that unit. The nurse has got to take orders. The doctor's got to write orders. The other doctor's got to accept it. That process takes a while. So you can already start to see where the flow starts to bog down right then and there. Now, here's the bigger problem. When we get into flu season, and we get into the cold season and the sickness seasons, now we got a lot of critical patients and a lot of sick patients all put in the hospital. So the hospital's filled up, now they're on red. Now you got the really, really sick patients in the beds, and you got more sick patients coming in. So here's what happens. The less sick patients from the really sick patients get bumped down, and then bumped down, and then bumped down. And maybe somebody gets sent out of the hospital that really would have been nice to keep them there for a couple more days, just to manage them a little bit better. They go home. Or their insurance won't pay, and then they get put out because we need that bed for a really, really sick patient. It's kind of like medical triage, if you will. And they're not really fine-tuned, and they go home and they eat a ham sandwich and it throws their salt content back, and then they come back in real quick. So that's a pretty vicious cycle, and when the hospitals get inundated, it's hard to manage that. So that's another component.
Can I add another layer of
You certainly
complexity
can, sir,
of that?
because you're more of an expert than I am in that.
As the one who manages surgical ICU beds at Hopkins every Monday and goes to codes, most hospitals now do not allow us to save a bed. That's number one. And
Okay.
number two, it's actually not a limit in the number of hospital beds. It's nurse staffing, right? So all hospitals
We were gonna touch on that.
Great. All hospitals are a business. So Hopkins, for example, we go based upon staffing the number of beds at midnight, and it's the average number. So they have nurse staffing that is in place based upon projections of how many beds are filled at midnight, the average. So meaning that there's no flexibility to go up, right? Because average is only 50% of the time. So 50% of the time, we don't have enough beds to monitor, to manage the number of patients that are physically in-house. So for most hospitals, this is a staffing issue. And there are many more beds than are nurses that are available to staff those beds, and that's an intentional decision that's made by every hospital multiple times a year.
So you can start to see the bigger problem. A lot more patients, a lot less staff, a lot less beds. Back when some of our older gentlemen and ladies in the room were growing up, you went in the hospital, it was 2 beds per room. Now everybody gets a private suite. Now we know that's probably intentional for staffing, and if I only put 1 bed in the room, I only got to staff at one person, but we're going to talk about staff and money in the bottom line dollar. Now let's start looking into our own systems, not just Baltimore County, but systems across the board. You have the 911 system. What is the 911 system? Because that's the start of every call. Is that a problem for us? Is it not a problem for us? Could it be worked out a little differently? Could that help alleviate the problem? Could that alleviate the call volume? Questions, comments, concerns?
The procedure, the guidelines, are not following those guidelines, is a problem. And then periodically, you need to adjust those guidelines as you find them to be applicable.
So it's fair to say that most larger jurisdictions have some type of system or process in play. They're held by a whole other group of regulations and standards. Those regulations or standards are set by a federal level and then a state level. They're following them, they're good, but sometimes they need to be tweaked. In Maryland, in Baltimore County, we use ProQA, we use EMD, EFD, and EPD, which is a nationally standardized system that we can tweak and play around with a little bit on us. We have fire-based systems. Now, we're very fortunate, I believe, in Baltimore County that we have a combination system, and I think from the literature I've read and from talking to people at the National Fire Academy, it really does work well. Even though we have hiccups here and there, we don't have combination stations, we don't have half-staffed equipment, we don't have volunteers and careers running together, not that that's a bad thing, but we have set stations and set companies with set guidelines on number of personnel and manning and so forth and such, which really helps a lot in the bigger scheme of things. But when we look at the career services EMS, it's just like with anything else, it's a business. As Dr. Barinholtz said, in the hospital, it comes down to the bottom line dollar and staffing and money. It's no different for us. So now you got a set budget. You got to work within that budget. You got a volunteer system that does an excellent job at supplementing. However, nationally, we know that retention and getting volunteers that, look, it's a plain and simple fact. I need money. You need money? You probably don't volunteer as much as you want to, right? Why? Because you're out working, right? But if they paid you some money here or a lot more money here, you'd probably be here more, right? So, I mean, again, it comes down to money, resources, and time. And then unit availability. In our system, we got a unique system. And we're really not any different than any other jurisdiction. You either got ALS or BLS. We could talk about privatization and private ambulance companies, systems, and things like that. That would eliminate a lot of problems, but in my opinion, it's something we should never explore because we work well as a system with EMS in it. You go out in California, for example, they have engines in every other station. The paramedic goes out, that treats the patient, AMR comes in, picks them up and gone. We probably wouldn't be talking about half the problems we had today if we had a system like that. We would be talking about a whole nother level of problems. Stan, did you have a comment or?
And it's the old fire-based systems of changing the culture in the fire department as far as it's even though it's called the fire department, it's an EMS department. The majority of the calls are ran for EMS. Now, privatization and the different, as far as the aspect that that's concerned, right? And I've seen it across the country, to where then you get in the business side of it, and it just pulls and pulls and pulls, all right, to where your EMS providers aren't making the money, and your EMS providers aren't being held to the standard, so on and so forth.
Whole nother level, like I said, we went down that rabbit, a whole nother level of arguments.
The big thing I believe on the East Coast and this upper East End is the fact that you have old school fire departments that are slow to move in their old times and their customs and their legends.
Which brings me into this segue. So one of the challenges right off the bat is that history, mindset, tradition. Is that fair to say?
Yep.
Okay. So some of the obstacles we have to come is getting into the mindset that things are done a little differently than they used to be. We have to change the mindset of tradition and history. Would that be a fair assumption of what you just said, Stan?
Yeah.
Also, the ability to accept change. That's one of the problems in our by nature.
Yeah,
Just
teach
like
the
that,
old dogs
we
new
don't
tricks.
do well in accepting change.
Well, it's funny that you say that because there's the last three slides are going to address that from a psychological, sociological standpoint. There's some groundbreaking evidence out there about a thought process in everybody, regardless of your profession, and I think we'll tie it into that. But the acceptance of change isn't really that we don't accept change, we just have two mindsets, and that's great you said that, because we're going to go on that. What's in, Jeff, I haven't picked on you much, sir, but I'm going to pick on you. What's the biggest obstacles that we got to fight against? Well, obstacles to overcome, not fight against, overcome. What are some of the biggest hurdles we've got to overcome to do anything for that matter? Ooh, look at that. He got two of them right off the bat. Budget, education. And how about if we should say the fourth one is, and when I say administration, it's no dig towards the administration, but we'll say administration regulations. Is that a fair assessment? So administration regulation. Say again, sir?
Change in opportunities as far as administration is concerned.
I don't think I spelled that right, but you get my point. We'll just say change in circumstances.
No, it's opportunities, it's not circumstances.
Oh, opportunities? Okay. Well, it's changing opportunities.
Okay.
Now, sorry, that was loud. We talked about history of the fire service. It took 20 years back then, 25 years to actually formalize systems. We're trying to do all this in 10, 3. I'm sorry, do you got to move that every time I move? I apologize. Regulatory alone, there's got to be laws, and then there's got to be a process, and then of course that process has to go through. Just in our system, we have the administration, the operations, the union of the operations, the volunteers, the public, all that, and then we got the other agencies we got to work with. So that process can't happen immediately. No matter what we do, it cannot happen immediately. Fair to say? For the sake of, in all seriousness, we only got a few more slides to go through. I do want to make sure that we get the general point of what changing the culture of EMS, at least what I think.
Culture of the fire department to help out.
Well, yes and no. We'll get back to that, Stan.
Once told me.
We'll get back to that. So I think it's fair to say, career volunteer, we've already identified significant issues right off the bat, no matter what we do. Money, time, resources, personnel, just like in the hospital, as Dr. Barinholtz said, we don't have the staff, the money's an issue, education's going to be taking a while, all of that. So there's not variance between one or the other. We're all in the same boat, from the public level to the private level, no different. And because we're a public entity, it just takes a little bit longer because the money's regulated from the taxpayer's perspective. So the frustrations that we have, we got to understand that we're going to have them. It's just going to take a little while longer to get through them. So we actually did a lot before with the hospitals. We won't have to tie back into that. But one of the things we are going to have to do better moving forward is work more with the hospitals. We're going to have to incorporate ourselves with some type of plan with them to say, hey, this isn't working. You see that across the board nationally. It's happening now. We're working on it now. But when you try to work on it, what are we lacking? Resources and time. They're lacking resources and time. So the two things that we really, really need, both hospital and EMS and fire department, is resources and time. Neither one of us have an abundant level of. So it's hard to make that change happen quickly. Now, I don't want to get into a long discussion about this because this could go on for days. But I think it's worth warranting. And I want to tweak maybe why we're seeing it and how we can make it different and better. On a national level, both EMS, fire, the country, everybody's having issues. It's a stressful world. We all got to work and feed ourselves. We all want something. We all want to have a house. We all want to have security. We all want to be clothed. The stresses that we have as a society in general are just overwhelming. But EMS is even more overwhelming. There's a lot of terminology out there. There's EMS burnout. When I see EMS, I'm not excluding the fire guys, Stan. Public safety burnout. There is fatigue, and there's a word that just come out of compassion fatigue. Now, that's really important to know. Is that a thing? And I'm going to open this up for a quick discussion. Is all this a thing? Jeff, you're laughing, but you're saying yes. You agree, but you don't want to say you agree, or you hold, so.
There's variations of it. Yeah, you get tired of doing the job, but at a certain point, you're still doing it. However, your compassion level is not where it was when you first started.
And that's fair to say. I can honestly tell you, if I wouldn't have had the changes I had in my career to go more in the support service realm, to get a break and to see things differently, I would have been in that boat very easily myself. I was 7 years at Westview, and I had my last compassion fatigue set in when a patient told me he was going to effing kill me and my family. And this was after my 12th call for the night. And he basically called me and I get it. Like, we get it. Yes, Stan. Stan, the game's 10 minutes. I don't want to slate you in education, though. I'm kidding.
The point being also, along with that, with the high volume, and I know back when you came in long before me, when there wasn't that many EMS.
I didn't come in long before you. You were in before me. You came and went.
Okay, and I can remember Fullerton not having a geriatric living facility.
Mm-hmm.
All right, and now with the realm of the population of Baltimore County and the fact that it's call after call after call and it's no break.
So let me ask you this.
The thing that is when we started, it wasn't that much compared to what's happening today. It's bang, bang, bang.
Now, you ladies know Stan. Do you know Stan? Stan's archaic. He's like that guy that's been around for a long time and then came back again. Got a lot of answers. But you ladies are the youngest in the room. So here's what I'm going to ask you. Do you think it really is, because a colleague and myself were talking coming up here and going back at different points, and we were talking about call volume. And back in the day, when I was at 13, we were at 2,800 to 3,200 calls a year, which was, to me, a whole lot of calls. Now we're like 4,000, I think, give or take. So we went up about 1,000. So we're getting busier. But even when I was running that many then, and my colleague, such as yourself, and you guys were running, you were still running a lot then. I think it's fair to say you probably had your own variants of fatigue, burnout, stress, right? Here's where I would challenge everyone to say, I think it exists. I think it's a real thing. But I think it's misplaced. Does that make sense? Misplaced. Like, I'm not saying that it's not valid, it's not justified, it's not deserved. Here's what I'm saying. Do you think providers, and I'm going to ask you young ladies, because you young ladies are the ones that are coming up into the profession. If we gave you more answers to patients' problems, in other words, you come to me and you call 911 and I can't treat you. I don't have any medicine to give you. I don't have any resources to give you. I don't have any knowledge to address your problem. The only thing I can do is tell you, you don't need to go to the hospital, you need to go to the hospital. Is that fair to say? If I gave you options for those decisions, would that take a little less stress off your back? Other facilities, mental health facilities, urgent care clinics, resources, referrals. If I gave you answers to problems that you are facing with patients, that would take a huge stress off your back. Even if you had 25,000 calls, I would have an answer for you. So the stress is there, the unnecessary stress of not having an answer to help that patient.
Well, also the unnecessary stress of management and so on and so forth.
Exactly, and then you have patients with the complex needs. Hey, you're really sick, I need to treat you medically and get you to the hospital, but I know when you get out of the hospital, you're going to get sick again because you're not taking the medications as prescribed. Heck, you don't even have them in a pill bottle separator to take them appropriately. So we know you're going to go back because your problem needs to be medically managed because you were in the hospital for 5 days and they did great. So now you're not medically managed, you're going to come back. That's a stress, right? Right? I know I'm going to get that patient back again. So if we gave that patient resources to help them, educate them, and manage their problems, that would eliminate our need and our frequency of going back to that potential patient. And all this comes down to two things. We either don't have the resources or we have the resources and we just got to allocate you to the right places. Hence the mobile integrated health and things of that nature. So I think it's fair to say compassion fatigue is a thing. But I think it's also fair to say that we could eliminate a lot of that if we gave options to our providers to help our patients better. Is that a fair assumption? And then if they truly did have the PTSD and the baggage and the concerns from running the calls, we could legitimately address that as we need to. So we really got to work on giving our providers the resources to give the patient the care they need so that we can really worry about what's really going on with them if it really is going on with them. That's just my opinion for what it's worth.
But that's how it's happening.
Well, that's a debate we're not going to have in class, but certainly. Solutions moving forward. I think it's fair to say, and I'm not speaking for the administration, I think it's fair to say there's discussion at the state level, definitely, that's given these options. We talked about the ET3 that says, hey, look, for 5 years, if you want to dive into this, here's an option. We're going to allow you to do this from a state regulation mandatory process, and the Medicare and Medicaid is going to allow you to collect money for it if you choose to. That gives you some options, but here's the problems with that, and this is challenging, and I'll use Dr. Barinholtz in the back. We really got to be careful with not knowing anything about a patient to have clear-cut guidelines of who can go to these places and not. Because once you get to the hospital, they're going to draw labs on you, they're going to draw values, they're going to do diagnostics, and they're going to make a decision that we don't even have close to the information we need to make. So before we get to that level, there's got to be a lot of discussion, there's got to be a lot of fine line tuning to say this is what we can do. And that takes time and resources. But we know that it's working. We know that it's working in other jurisdictions. We know that it's working in other countries. There's other models. We have neighboring jurisdictions that tried it. Some of them tried it and didn't do so well. Others are trying to do it very well. We may just have to, in Baltimore County, if we choose to, find some variance that works well for us. And then there's the whole social service aspect. We here have the mobile crisis team. We have the Narcan Leave Behinds program. We have a lot of different resources to give to people. We've just got to get it put together in such a way that when you young ladies and gentlemen ride out in the medics, that you have the options to put these people with the people. Now, we're revamping a whole senior program, I understand. Is that true, Jeff? We're trying to work out the senior program? Yeah.
I like that answer. It's being looked at.
It's being looked at. So we're looking at, but again, it comes down to time and resources. We need more people to say, hey, we're making strides in the right direction, I think. But if we give you those options, we can keep those people out of the systems. The Narcan Leave Behind program, regardless of what you think of it, that's a state level mandate. The county administration said, hey, we're going to do it. It's a good thing. If you look at the national numbers, they are overwhelming. We're going to get back to the case review in a couple minutes, but you've already formulated that potential bias. Giving somebody Narcan, whether you agree to disagree, is the one true time you're saving someone's life. So we just got to change your mindset. When you get frustrated at that person you've just given Narcan 3 times in a trick, you've saved their life 3 times in a trick. You've done an outstanding job. So we've got to get the resources together to give you the options to send people where they need to go. And that'll take another load off of that component.
Do you have any statistics that let us know, after the Narcan program, how many lives have been saved?
Jeff, I think we get that, don't we? Director Shane, I think that information for you, for Baltimore County, I don't know if there's discussion about letting it out there, but I know the REACH program feeds that information back over, don't we, about how many people are. He wants to know if we have any statistics or numbers that show how many people are actually saved and worked with that program. Yeah.
I mean, there's signs that from a couple of precincts
Dr. Barinholtz?
So the REACH program, who gave a talk in this same series, shared that they do have numbers
Okay.
about the number of Narcans that are being given out to the community. They shared that they do not have a direct feed of data coming from the county fire department.
Okay.
to REACH.
Okay. So that's probably being worked on too, but we could probably get some numbers and maybe put that out. I'll talk to Director Shannon and see if that's something that he's looking into or has looked into. I don't want to speak it. Stan, you're not baiting me tonight, buddy. All right, so going back to that REACH program stuff. There's 4 programs that MIMS has out right now to address some of the bigger problems. It's a pilot program. I'm not sure where we are with any of that, so I'm not going to speak out of my wheelhouse. We have the Alternative Destination Program, which ties into the ET3 money. We have Minor Definitive Care, which is something Baltimore City started. I think they were trying to ramp that into a state thought process pilot program.
Well, actually, they started into it.
Well, they started into it, yeah.
And the state didn't prove it, they went on their own, and now the state's tagging along.
Is that what it is? Okay.
And also what they brought in is nurse practitioners and PAs running with, because of the fact that the Affordable Care Act, and if you return to the hospital sooner than that number of days,
Right.
they don't get paid.
I think the really important thing that if you get anything out of this lecture tonight is, one, we're really doing a good job, but 2, a lot of what we're feeling right now is managed healthcare. Back in the day when we were just starting out in EMS, our jobs were simple. Go out and keep somebody and save their life and bring them to the hospital. We did that so well, believe it or not, nationally we were doing that so well that, 1, they recognized us as an EMS professional and a medical professional, but 2, now they're saying, hey, you did that well, you managed that well, let's start helping, you help us manage these patients that we just got inundated with better. You're a vital component of a system. We can use you and utilize you to help manage that problem. And that's kind of where we are. So we're in a huge, and if you look at the 20-year cycle that it took to go from not being anything to establishing a system, we're actually midstream right now. So we're not doing pretty bad. I mean, we're already making strides towards a goal that we might meet. So here's what I want. I'm sorry.
A comment that was shared online. She said, Beth said, one of the resources I need to take the best care of my patients is to get feedback on my calls. All cardiac arrests should be annotated and reviewed with crews.
It's great that you said that, because as we stand here, and I know Lieutenant Fitzpatrick, he's left, but we are already working on that, and I know he's taking charge of that, and it's being worked on, as Captain Willis just said. We are looking into ways to do that, and I think we're evolving off of that well, where we take a cardiac arrest, we're getting more officers and more resources to actually inundate that code pretty quickly and get back to you in real time. Look, I'm not going to lie to you. I think the only way that we learn the best is as soon as we can after the call. The fire side is doing this well. They have after-action reviews. And I always equate a cardiac arrest, if you will, to that working fire, because when you're a firefighter and you're riding that engine, you're looking, I don't want to say looking forward to that working fire, but your primary purpose is that working fire, to get in and save somebody's life, put their house out quickly, and reduce that damage. In the EMS world of things, and when I say EMS, I know the fire people, or the fire side is huge with us, but our working fire is that cardiac arrest. So yes, we want to get that feedback as quickly as we possibly can, and that's a big thing to work on going forward. So here's that thing I was talking about. This is not a concept in EMS. This is a concept, this is groundbreaking thought process in education and psychology. The stresses that we're feeling in any profession, they've come down to two thought processes here. And the gentleman's name, let me look, I'll tell you what it is in a minute. He's from the University of Stanford. Carol Dweck is his name. He come up with this concept that it's not that you're frustrated, it's not that you're stressed, it's just that maybe you have a fixed mindset. Now, don't shoot the messenger, because I'm not saying that if you're this way, you have a fixed mindset, but here's what I'm saying. If you get stressed, we're just asking, maybe change your mindset. Does that make sense? So with the fixed mindset, it says, I'm only good at certain things. How many people in here have gotten to the point where they get to the point where they've gone so far and They don't know what other their options are. They don't know any other solution, and they get agitated or ticked off. Is it fair to say all of us? Okay. Does anybody in here give up when it gets too hard that's willing to say that? And I would think it's fair to say in our profession we don't. Because of the profession that we're in, we're not built to give up. We're built to move on and overcome then adapt. So that's a good thing. What's that? Well, does anybody in here hate challenges? Because I think it's fair to say most of you in here love challenges. And that's a good thing. So the point I'm going to start making in the next slide is a couple things. I take feedback and criticism personally. I think it's fair to say everybody does at some level. But does anybody really dwell on it? Kat, is it fair to say in your years of experience as a supervisor that you've had anybody that really just shuts down when it comes to criticism? And
I don't think that's necessarily pertains to us as a group as far as EMS professionals.
It does or doesn't?
It does not.
Yeah, I would think so too. Everybody takes a level of it, but they don't really just shut down when they get it. And I don't like doing what I don't know. So here's the point I try, and we're going to get into the growth mindset. So I think it's fair to say we've established in our profession, if we're being honest, most of us as a whole, we're not fixed minds. So the frustrations that we're having are legitimate, not because we're shutting down and just don't want to see other options. That's a good thing. I think that's a great thing. Stan?
The other thing is overwhelmed.
You keep saying overwhelmed, Stan. We've already established that we are busier.
Yeah,
but we've also established...
You're listening to a suppression captain tell me about
No. A suppression captain, that's a paramedic, and road... Okay. That's where we're going. Look, straight up, honest to God as I'm standing here, if I wouldn't have made the decision to go support services and teach one day, I might be that same person. Whole nother argument, whole nother conversation.
Well, that's where...
But let's get into the growth mindset. The growth mindset is I can be good at anything. If you're sitting here and you say to yourself, I can be good at anything, that's a plus. I try until I get results I want. We try until we get results. And we try, and we try, and we try. I embrace challenges. I welcome feedback and criticism. I learn about things I don't know. So we can apply this concept. We actually just applied this concept in PDI, which is Professional Development for Instructors, Saturday, from the educational realm. I think if we applied it here, I think we can prove that in our profession as a whole, we're growth-minded people. Would everybody's consensus agree with that? So that's a good thing. So, I segued into this slide, but I answered the slide before I segued in it. We, as a profession, can say that we're willing for our next challenges, wherever they mean or need to go. Let's get back to our case review. Is there anybody in here that honestly wants to say they formed an opinion about this guy? I formulated an opinion. When I was putting it together, I was like, now, I was going to do a little scenario before we started. Truth be told, I was going to take a group of people, 2 providers, and then I was going to take another 2 providers, and I was going to whisper in this group, I want you to pretend that you're the worst provider that you have in your mind and do a little reenactment. And then I was going to take this group and say, I want you to pretend you're the best provider you've ever seen or dealt with in your mind, and we were going to do a little reenactment. I didn't think that would be fair. But it's fair to say we've all got that one person in our mind, in any jurisdiction, in any department, that if we're really, really sick and they show up, we may be praying to Almighty above, saying, Dear Lord, here I come. And then there's that one provider in our mind that if they show up, we're like, I'm going to live another day. Thank you, Jesus. Is that a good assumption, maybe? So, getting back to our case scenario. We looked at this gentleman. He overdosed on Narcan. He had some chest pain. I shouldn't say chest pain. He overdosed on heroin, took Narcan. Family gave him Narcan. Mom and kids rolled out, he's holding his chest. Agitated and combative or argumentative, but not combative and not unsafe. Okay, got that, right? We saw the conditions of his house. A third of us want to get out of there as soon as we can. We're icky, you're nasty, you're disgusting, whatever. Empathy, compassion, or compassion, what is that, compassion fatigue? The compassion fatigue is you know, it's the 12th call of the day, you're a schmuck, I don't want to deal with you. But, let's talk about treatment. Do we need to treat that guy with anything? That patient, that scenario, does he need to get any medicine from us?
Well, you first need to be evaluated.
Forget all that. We've already done that. If we're ALS, he's on the monitor, he's all that other stuff. If we're BLS, we give him oxygen, did his vital signs, all that other stuff. First of all, is this an ALS patient? Who says yes, who says no? Okay, I'll say yes, okay. Well, if you put him on a monitor, it's in science tag.
Yes, because of his chest pain, or you say ALS?
Well, because he's holding his chest. And he overdosed on heroin.
What if he got a steroid?
Okay. Jeff, you bring up a very good point. Here's my point. ALS or BLS? It's always safe to say ALS, but let's look at the challenges we have. Let's look at the challenges that we have on any given day in most jurisdictions. Let's say for the sake of argument, you're right here and it's AMBO 325 or AMBO 19, and your next two paramedics coming from Towson. How far away is Sinai from here? How many? 10 minutes. Let's say your ETA from the closest medic is at least 15. Is it a BLS patient? Yes. When we talk about changing the culture of EMS, and I don't want to get off on a tangent, but I think in my experience in many different jurisdictions, but I wrote up in Carroll County, and you Jeff, you live up in Carroll County, or did live up in Carroll County, right? And I live up in Harford County, and I work here, and I volunteer here. They're three totally different areas in how we do things. In Carroll County, you weren't getting a supervisor, and there wasn't a paramedic coming. In Harford County, you were not getting a supervisor, and you may or may not have gotten help. So we did a lot of things in those two, I did a lot of things in those two jurisdictions that in here, I've had the luxury of saying, the paramedic unit's coming. Me being the paramedic, I never had to worry about that, but we've done, I think, to some degree, unintentionally, our BLS providers an injustice. Because we haven't allowed you, through the pure luxury of having a nice fluff system, the opportunity to be a strong provider. Not saying that you aren't or are, but you have the ability to drop back and punt and say, I'll just wait for the ALS unit, which is good. But you need to understand, if this patient is an ALS patient, but your options are better taken at BLS, you can treat him at a BLS level. You just treat him to your level of care and get them to the hospital quicker. Now, what I didn't tell you is this case review, we had a couple cases where patient had the similar experiences, and they both went to the hospital, which is a good thing, because even if they go to the hospital, whether they go to the waiting room or whether they go to the back, they at least went to the hospital. So the good thing is that the provider said, hey, you're going to the hospital. But here's what I want you to understand. When we fall into that the compassion fatigue or the burnout mentality, whether it's justified or not, and let's say for the sake of argument that it is, but if we eliminate that by giving you other options, then it's not, unless you have a true reason for it to be. Does that make sense? That maybe you'll always do the above and beyond with every patient. Is that fair to say, Stan?
No, because there's the fear.
We're not going down that road either, Stan. So if we eliminate that fear, that perceived or not, and we tell you it's okay,
Right, I agree.
then we can.
It lets you expand.
And I like to say that, is this patient in this scenario, is this patient at all a refusal? Would anybody truly gotten a refusal on this person? Now, what if they, Jeff, you're looking like?
Well, I was just going to say, if he's like, he was kind of combative, and if he adamantly refused, and we did a consult and everything like that, and he still didn't want to go. I mean, if we went above and beyond the call of duty to try to get this guy to go to the hospital, which he should, obviously, he still didn't want to go.
So leave him smart.
Yeah,
So
well,
here,
maybe leave Narcan behind, REACH program, throw some other options at them so you can say, hey, look, I did the best for that patient. Social services to, help them straight out of this department and have better hygiene.
So that brings up the other greatest point. Whether you take him to the hospital and tell the nurse he's got to go back to the back, I think he's having a heart attack, but I'm a BLS unit, and I couldn't do a 12 lead, and I couldn't give him this, I couldn't do that. Or you take him to the hospital and say he's having chest pains, but I can't do anything, and they put him in the waiting room. Or whether he refuses and you document and do everything you can, none of those three things are wrong. And I think with what Stan was implying, which I won't bite on, is if somebody says they're wrong, then maybe that's a cultural thing we need to change. Now, if you refuse them and your document says patient overdosed on Narcan and family gave him, a patient overdosed on heroin, family gave him Narcan, done, well, that's a problem. And that's on you. You got to own that. That's not the system, and that shouldn't be fear because that's you. That's what we got to change too. We can't drop back and punt and say it's the administration's fault or the officer's fault all the time. There's got to be that ownership in your practice. And whenever you do the best that you can under any circumstances, you've done the best in your practice. If I'm on a fire ground and God forbid someone's house is burned down, but I've done everything I can to not try to do that, I've done everything I can to not do that. It's no real difference. It's just that you got to make the effort to start. So I kind of hope that helps. So I think in this review we have solidified the history of EMS and why it's important to understand that. It took 20 years to develop ourselves as a system and then for us to be recognized as medical professionals. And we're trying to do from what the 2010 agenda said, we're trying to do that real quick. It's going to take some time to get there. We're going to get there. You need to understand that we're going to get there, and you need to understand that it all comes down to three big things: money, resources, and time. It really does. It's that simple. So we just got to keep working at them. We debated, we defined, we talked about all this stuff, and I think it all made sense. Did everybody feel like they got you younger ladies that haven't been around a little bit longer, do you feel like you got a bigger picture now of how things work? I mean, did it ease any frustrations or concerns you may or may not have moving forward? Are you fearful of going, are you an EMT? Are you going for your paramedic? Why not? Oh, you're going to... I'm going to med school. I don't need this paramedic stuff. Good for you. Keep going. I don't want to try to stop you. I tried to. I didn't want to. Good luck. How about you, ma'am? You're going to be a paramedic? Med school, PA? You're dabbling in all the options? Well, good luck to you. Any other questions, concerns, comments? Don't say it. He doesn't want, don't talk about it. All right. So if nobody has any questions, I really want to thank you for your time. This is much more of a turnout than I thought would be here tonight. God bless you all. I hope you got something out of it. I hope it meant something. If you have any questions, comments, or concerns, give me a call anytime. I may or may not post this of myself once I see it. So just so you all know, there's 3 already previous lectures on the LMS. As soon as I'm able to, we have all the previous lectures. I have them formatted into an MP4 audio file or video file. A lot of the times of expiration expired for MIMS. So as soon as I get a new number and new credentials, I'll put them online as I get them for credits if you haven't seen them previously. Don't double dip because we really haven't figured out a way to make sure that doesn't happen, so I'm going to hold you on your honor on that. If you've seen the class live, don't take it on the LMS. I don't want us to dabble down that road, but I'm going to try to get them online as soon as possible. Any other questions? Thank you all for being here. I appreciate it.
I also just want to give a quick shout out to Akiva, Ashley, Hunter, Avi, and Joe, who's not here right now, for helping us run this lecture. Thanks to the young people who know how to do this stuff and make this available to everyone around.
Thank you very much, all. Appreciate it.